This short video has been made to help healthcare professionals hear directly from people experiencing homelessness and those supporting them about what it's like to live in a hostel when your health is poor. We hope it'll help foster more collaborative working and so improve the quality of life for this vulnerable group. I'm a GP and I've worked with homeless people in the community and also within a hospital setting in a hospital homeless team, and have become increasingly aware really of the complexity of need of homeless people. They often have a combination of mental health difficulties, substance misuse problems, as well as often profound physical health problems at a very young age.
My partner who's passed away now was tenancy holder of her flat. Yeah, she passed away with meningitis. I've come home one night and it's all boarded up. Yeah, I lost it all. The photos, everything.
I lost my mum and my missus within a month, and I sort of like lost the plot for a bit. I just ended up on the streets and I ended up lost. Yeah, I took a few overdoses on my medication and I was cutting my wrists quite a lot.
Rarely have I come across or heard a story that doesn't involve a loss or a trauma, quite often from their childhood or a breakdown of a marriage or a death. Very rarely do people choose to be homeless. When you look at what homelessness is, it's not just the loss of the physical structure of a home, it's the loss of the support network.
The fear of not having a home is like not having no feet to stand on. You're coming out back to the streets, so you're not going to get better, you're just going to get worse. You know, your treatment, they might send you out of the hospital early and you might need to heal a bit more, but you'll be out in the rain and the cold.
Homeless people die young, with the average age of death being in their 40s. And in the past year I've seen a number of people within their 20s dying. When they get sick, they often don't go to hospital or delay going until they really have no choice.
It took me nearly dying of double pneumonia to come off the streets. I now know that my lungs was full up with liquid. I couldn't lie on either side. I had to sit up with my back against the wall to go to sleep. And at that point I knew I was really ill. Like myself, I just didn't want to go in because I was grubby.
There is definitely a stigma attached, and when you go into the hospital, you know, a lot of residents sometimes they don't present well. They might look unhealthy. They might look a certain way. When I've been to appointments with clients, is the doctors to talk to me, and I'm thinking, you don't have to. That's the person you need to talk to, not me.
I've been suffering with numb legs, numb hands, can't walk properly. Without the crutches I lose my balance. I can only take little tiny steps. And I went to the hospital and they wanted to keep me in because I didn't have enough, I didn't actually get a chance to get any gear that morning. I basically discharged myself because I was trying to stay there. Without any gear. Gear is heroin. If I didn't have it, I would have gone into withdrawals and I'd have been sick, I'd have been hot, sweaty, vomiting.
That particular time, it took us quite a long time to get him to an appointment. It was quite important, and we'd worked very closely with the GP. We'd worked very closely with him, and then we got a bit of trouble with the security. And you know, they was literally trying to chuck him out of the hospital. I don't know, I didn't like the way that he was being treated that day. So
acute medical wards are extremely busy places, but I have seen huge delays in people receiving their methadone, and this can result in a lot of distress and suffering and increasing agitation. The result of this is people often self-discharging, or worse still, their behaviour becomes so challenging that they get evicted from hospital. This often means that they actually don't receive the life-saving treatment that they really need. Timely delivery of methadone has to be seen as a priority.
It's so important to look past that addiction, to look past that challenging behaviour and look at the person for who they are.
It's not you as such, it's your illness, you know, it's the be all and end all. You have to have it.
When it comes to hospital life, we've got to be very sure.
Somebody may be able to self-care while they're in hospital, but in the community they may be very isolated and may not have anybody to help them with their day-to-day activities.
I can't cook in that anyway, yeah, but what I generally do is I pay someone to go and buy me some chicken and chips. I'll say to someone, "Look, do you want a beer? Can you go and get me some chicken and chips from the shop?" and that. And yeah, that's what I've been living on, chicken and chips. And probably do something without the stairs, you know, because them stairs are a problem, them doors are a problem.
Because I can't read and write, I'm dyslexic as well, and letters really scare me a lot. So I get my key work, I do all my letters.
Quite often we'll see them back, they will be discharged sometimes at 2 in the morning, 3 in the morning with no warning. Self-discharging can be a big problem, and for that reason there's no discharge summary or information from the hospital about what's happened, about the reasons why they were admitted in the first place.
One of the main worries is getting the treatment for a particular resident and getting them to the hospital, where some of the residents we have who might be suffering from severe depression, they may have given up on life, so they won't attend their doctor's appointments.
Their addictions can be so much that they suffer from liver disease that can result in their death, and that can be very, very difficult for hostel staff.
People are often discharged from hospital without their discharge destination really being considered or understood. Now, for people who are homeless or vulnerably housed, squatting, sofa surfing or in a hostel, they may need to be much more well than somebody who's going back home to a family. Hostel and day centre staff can be a really useful resource for medical teams as they really understand individuals and the complexities of their need. So it's very useful to use them when care planning for a discharge for a patient.
I think usually if it works well, they will invite us to the ward round and a discharge meeting, and we can set up some sort of care plan on when they come back.
It's our joint responsibility to share the burden of what's happening and try to better or improve the quality of life for that person for the time that they have left.